Okay, so welcome everybody. I am Katie Rasmussen, Director of Business Development for Aurora Behavioral Health. We're very excited for today's webinar and that you could all join us with Dr. Ghafoor. Everybody's been waiting for this one, so we're excited. If you're not familiar with Aurora yet, we are a level 1 psychiatric stabilization hospital for ages 12 to 17, 18 on up, and we have a specialized needs unit for kids 8 to 17. ECT, partial hospitalization, and intensive outpatient. And we really stand out for having a very holistic mind, body, soul approach. If you are not familiar, have not toured us, come to see our equine or adjunctive therapies, met our chaplains yet, please reach out. Our team will do a quick intro as well and put their information in there, and we would love to tour and connect with you. So Erica, if you want to go.
Yeah, absolutely. My name is Erica Rutter. I'm on my 3rd month with Aurora Behavioral Health. I'm a community liaison. I cover Phoenix, Scottsdale, and everything north. So I'm excited to connect with you all. I'll leave my information in the chat so you guys can have it, and feel free to reach out if you have any questions. On to Val.
Yeah. Well, hello, I'm Valerie Purdy, and I also am a community liaison here. I have a little different role. I work internally in the hospital, and I meet with patients and enroll them in our awesome outpatient services at both hospitals. And then I get to work real close with our social service team with making recommendations on some of the programs out in the valley, around the valley. So I'm glad to be here. Glad you're here. Thank you.
Hi, I'm Carly Bodette. I'm also a community liaison here at Aurora. I cover mostly the East Valley, so maybe over Chandler, Tempe, where one of our hospitals is. I'm really excited to, learn from Dr. Ghafoor and have him share his knowledge with all of you.
Awesome. So a couple quick housekeeping. Please, any questions that you have for Dr. Ghafoor, he'll take a couple pauses throughout the presentation and we'll get to those, but make sure they're in the Q&A so they don't get lost in the chat mix. You are all muted, so any questions put in the Q&A. You will receive a copy of the CEU certificate and Dr. Ghafoor's presentation via email next week by the one that, whatever email you use to register for today. Otherwise, we're ready to get started. What the reason everybody's here. Dr. Ghafoor completed his undergraduate degree in physiology and minor in Near Eastern Studies from the University of Arizona. He then attended Dartmouth Medical School, now known as Geisel School of Medicine. He completed his residency at California Pacific Medical Center in San Francisco and his child fellowship at Creighton University SOM Phoenix program. Dr. Ghafoor completed an additional fellowship in Addiction Psychiatry at the University of New Mexico with a focus in adolescent substance use disorder. Dr. Ghafoor is currently board certified in general psychiatry, child and adolescent psychiatry, as well as addiction psychiatry. He currently sees patients ages 3 through 18 at his clinic at Transition Center in Tempe. Dr. Ghafoor, it's over to you.
All right. So just a shameless plug, Transition Center. I work over there. I see adolescents. We are just down the street from Aurora East. So we're very close. It actually makes it very convenient for a lot of our IOP patients too. They'll see me and then they'll go to IOP. This is the number for our intake line, our emails, our intakes email. We take almost all the insurance plans for kids and teens. For adults, we take almost all the major private insurances like United, BCBS, Aetna, Cigna, all those, and more. All right, enough of that. All right, so why we're here. So before I go into like really interventions for different states of change, I thought it'd be good to just kind of go over what are the different states of change. So this is an overview of the trans-theoretical model, which was developed by Prochaska and De Clemente back in the late 1970s, early 1980s. It consists of 5 core stages of change, as well as a 6th stage, which some people include, some people don't. I personally like to include it, which is relapse. So the states in order are pre-contemplation, contemplation, preparation, action, maintenance, relapse, and then after relapse, you may get into, and you may re-enter the cycle in any one of these states. All right, so going into more detail on pre-contemplation. Historically, pre-contemplation was never really targeted for interventions. Clinicians who treated substance use disorder considered patients in this stage just refractory to intervention. Thus, this population was not really targeted. Various explanations in the past have been, well, they haven't hit rock bottom yet. Their loved ones are enabling them, or their defenses are too strong or too immature, or they lack any insight into their substance use. So some of the possible interventions that have come forth over the last 100 years, I would say, include craft as well as harm reduction. I'll often get patients who say that they want a very natural remedy, and I tell them that, well, you can't get more natural than lithium. It's on the periodic table of elements. It's as natural as you get. So with lithium, the main thing, you want to avoid MDMA because it's often used in these settings where you can get heat stroke and dehydration, and lithium is very sensitive to your fluid levels. So if you're dehydrated, your lithium level will spike, and that can cause lithium toxicity, which can manifest like tremors, altered consciousness, nausea, vomiting, difficulty walking, so a bunch of not so good stuff. And similarly with stimulants and alcohol. Stimulants also act as a diuretic, and alcohol can also impact your fluid levels, and then also has an interaction with lithium in that both are sedating, both can impact your balance. So generally, you don't want to consume heavy amounts of alcohol if you're on lithium. There are patients out there who are on lithium and will have, let's say, a glass of wine with dinner. That's not, to me, as nearly as concerning as binge drinking. All right. Valproate, valproic acid, Depakote, all names for the same medication. The substances that are listed here, you want to avoid using these substances with Depakote, specifically because of the risk of sedation and respiratory depression. So you don't want someone to stop breathing, and Depakote, as well as many other anti-epileptic medications, does carry that risk. Valproate or Depakote is often used in bipolar disorder, as is lithium. Antipsychotics. So antipsychotics, we will often use, obviously, in schizophrenia and other psychotic disorders, but we will also use it in bipolar disorder. Sometimes we'll also use them as adjunctive treatment in depression. So with antipsychotics, I would say you do not want to use any hallucinogens because and some antipsychotics may actually worsen the psychosis induced by the hallucinogen. In fact, for some hallucinogens such as PCP, the first-line intervention that people recommend is actually benzodiazepines, and only if those benzos don't work, then you go with second-line intervention of like haloperidol or droperidol, which are antipsychotics. So, even when we have an acutely psychotic patient with a psychosis that's secondary to a substance, the first thing we do is put them in a quiet room with, not too many stimuli so that they can just naturally recover. Second thing we do is we might give them a benzodiazepine, and then last thing we might do is give them an antipsychotic. So that's why you don't want to use antipsychotics while if someone is also using hallucinogens, because it could worsen the psychosis from the hallucinogens. Opioids, you want to avoid with antipsychotics. So like I'm particularly thinking of fentanyl and heroin. Some antipsychotics can cause respiratory depression and QT prolongation, which antipsychotics and opiates, they can both do that. So what would happen is that they have an additive effect, so that if you have if you're already your breathing rate's already a little slowed because you're on a heavy dose of an antipsychotic, the opiate may put you over, and you may stop breathing. QT prolongation is a medical term. It basically just means your heartbeats are spaced too far apart. The reason why that is dangerous is because if your heartbeats are spaced too far apart, you might induce an arrhythmia that could make your heart just not pump properly, and it could just cease to function. So that's why you want to avoid, even when we have patients on antipsychotics and methadone, we monitor them very carefully. So, you want to, if someone is on antipsychotics but is also using opioids, it's something that ideally you don't want to, you really have them maybe see an addiction psychiatrist, because there are a lot of patients out there who may have schizophrenia but also want to use opioids. Ideally, they should be seeing an addiction psychiatrist who can kind of manage that. Stimulants. With stimulants, obviously they can cause psychotic symptoms. You can use stimulants and antipsychotics together. It's just a lot of times you won't know if the antipsychotic is working. For example, if someone goes on a methamphetamine bender or a cocaine bender, and they're acutely psychotic and they're supposed to be taking an antipsychotic, or they are taking their antipsychotic, it may not work. So you might just be giving them super therapeutic doses when really it's the stimulant that's causing the psychosis. When I was in training in San Francisco, there was a lot of methamphetamine use, and I cannot tell you how many times I saw people diagnosed with schizophrenia when actually it was just methamphetamine intoxication. And that's what it primarily was. It's just that they didn't disclose it. And cannabis. So just be mindful that with cannabis, cannabis is actually more likely to cause a psychotic disorder than even methamphetamine. So cannabis is highly linked with psychotic symptoms. And later on, we'll be talking about this. But if there's a family history of schizophrenia or a psychotic disorder, I basically tell the patient, like, look, you basically can't use marijuana. Like, just like if your dad had a massive heart attack and is, has high cholesterol and diabetes, yeah, you cannot drink regular soda and just eat tons of cake and ice cream. Like, it's not an option for you. Sorry, that's just your genes. Same thing with cannabis and schizophrenia or any other psychotic disorder. All right. Harm reduction. So the rationale for harm reduction is pretty simple. Basically, we're going to try to minimize the negative impact of problematic substance use while enhancing quality of life. There are 6 core practice areas to harm reduction and 12 harm reduction principles for providers. So these are kind of the 6 core practice areas where harm reduction is really guided by people who either use or have used. It embraces the inherent value of people. It commits to engagement and community building, promotes justice, equality, and equal rights. A low barrier to access, a non-coercive approach, and you want to focus on any positive change as defined by the person. The core principles for us as providers, whether you're a therapist, a medical provider, you want to respect their autonomy. You want to create a space of acceptance and hospitality, provide support, connect with family, specifically their family, provide pathways to well-being, value practice-based evidence and practical experience, not just, evidence-based, but practical skills and practical experience as well. Cultivate relationships. Your job is to assist, not direct. You're going to engage people first. You prioritize listening, and you're working towards system change. All right, so here are some more specific strategies. So some strategies include safer injection practices, such as needle exchanges, syringe services programs where you're exchanging the syringes, drug test strips, which include strips that will test for fentanyl or xylazine in the supply of the drug to make sure they're not contaminated. Overdose education, naloxone distribution, and then as well as protective behavior strategies. That's going to be our main focus of harm reduction, especially because I mostly work with adolescents, and I find that this is quite helpful when I'm talking to teenagers or their families. So specifically for cannabis, one of the best ways to practice harm reduction with cannabis use is to delay onset of use. So if you can delay the onset of use to after the age of 16 or 21, there is a much better prognosis than if they're using like at age 12 or 13. Prioritizing low THC, high CBD strains is another strategy of harm reduction. I often talk to adolescents about this, and most of them don't even know the THC content of the carts that they are using or the whatever other cannabis product they are using. So there's a lot of education that I wind up providing to them about, well, this is a cart, this is flour, this is what the difference is. And you really, and I try to speak to what is it that they're trying to get from the cannabis. Like if they're trying to relax, my point to them is, well, then you ideally would want something that's high CBD and low THC. A very high THC strain or a cart is not going to produce the same sort of relaxing effect that a low THC, high CBD strain would. So when you put it that way, I think teens are a lot more likely to listen because it sounds like you know what you're talking about. Avoid synthetics. I think that this is actually a lot less prevalent, at least from what I'm seeing, than it was in the past. Fewer teens nowadays seem to be using K2 and spice. I have a very small sample of the teens who are coming to Aurora and my own practice. So I can't say that across the board for Arizona or the United States at large, but from my conversations with them, it seems to be less, which is good actually, because K2 and spice and these other synthetic cannabis products can lead to even worse symptoms than the cannabis itself. So, all right, edibles. What I advise, 10 milligram limit. Wait an hour and a half to 2 hours. Don't drive, don't work. And yes, if you're under the age of 18, school is work. So don't go to school after doing an edible, don't drive, don't go to work, and keep a 10 milligram limit and then wait, an hour and a half to 2 hours to see what the full effect is before trying to take more. I just admitted actually, like very recently, a teen who had an edible which contained almost 200 milligrams of cannabis, and his friend just ate the whole thing all at once. and then wound up having a seizure. Yeah, so this is why, like, again, it's a harm reduction approach, because if you're going to do edibles, that's how you do it. And honestly, one of the things that I will advise teens, because oftentimes they have little brothers or sisters, or sometimes even kids, store it securely. Do not just leave your edibles lying around. That's a great way for a toddler to get into them and, wind up in an emergency room. Psychosis, pregnancy, and ADHD. So these are three conditions where I just tell them flat out, really, you should not be using. If you're psychotic, it's just going to make your psychosis worse. I will still give all of this previous harm reduction advice, but I will also tell them that really you shouldn't be using, because, like I said, it's like a person with diabetes just drinking regular soda and eating tons of candy. You're not doing yourself any favors. It's not, that you can't handle it. It's your genes. Your genetic makeup, your physiology is not one that is compatible with marijuana in its current form. Same thing with pregnancy. I will advise that, a lot of women will use cannabis or cannabis products for morning sickness. And I will say, well, it has been linked to ADHD when, kids are exposed to it in utero. It's been also linked to learning disabilities and other problems later in life. It's kind of deceptive because you won't see it right away. It's not like opioids where you have neonatal abstinence syndrome, but like when they enter school, it's there. And then ADHD, I tell them, like, look, if you want your ADHD treated, or if your ADHD is causing problems, you can't use marijuana, because I won't know if the medication I'm giving you is working. The marijuana is going to make you feel forgetful. It's going to, cause you to have poor focus, poor concentration, lose track of conversations, which is very similar to ADHD. So if you're using cannabis actively, and I'm giving you a stimulant to counteract your ADHD symptoms, how do I know if the stimulant's even working or not? Because what you're then going to say is like, hey, doc, the stimulant's not working, I need more. And then I'm going to give you more stimulant, and you're going to either be more anxious or your appetite's going to get suppressed. And then you're going to wind up using more cannabis to counteract that. And then you're going to wind up needing more stimulant. And then you're going to use more cannabis. And we get into this vicious cycle where I'm prescribing more stimulant, you're using more cannabis, and nothing is getting better. So those are the three conditions where I'm just like, marijuana, you really probably shouldn't be doing. Alcohol. So in some ways, this is easier in terms of a harm reduction approach, because the harms of alcohol are pretty well known. In other ways, it's harder because it's more socially accepted and more accessible. I will say, actually, cannabis is now pretty accessible given the dispensaries. When I was in high school, alcohol was far more easily accessible than the marijuana was. But some ways to engage people in harm reduction with alcohol: try to record your drinking. Record how much you're drinking. Try mindful drinking. Try recording how much you're spending on alcohol in a given evening or a given, one night. Plan ahead. Think about what you're going to be doing, over the course of drinking. Are you going somewhere to drink? If you're going to be going somewhere, how are you going to get back? If you are going to be drinking and you are going to be drinking around the time of a meal, maybe try eating a meal with the drink, because that will decrease the effects of the alcohol. It's better to drink with food than to just drink by itself. And if you do have a heavy drinker and you give them the choice that either you're going to eat or you're going to drink, guess which one they're going to choose. What does it do for you? Start asking that question. what does the alcohol do? Does it help you relax? Does it, make you more social? Does it relieve anxiety? Does it allow you to have fun in some way? Is there any other way to accomplish this without alcohol in the mix? Do you have to have alcohol in order to relax? Really? Like, you can't think, and start asking those kind of questions to get them thinking, like, well, yeah, do I really need this? Do I really have to drink in order to have fun? Don't drink alone. A lot of people, this is one of the things I will ask teens is, well, are you drinking alone? Because I get more worried if a teenager is drinking alone than I do if they're drinking in social situations, because when they're drinking alone, they are truly just drinking to get drunk. That's the goal. Or buzzed. They're drinking to deal with something. When they're drinking in a social setting, they're mostly drinking to have fun. So that's what worries me, is when people start drinking alone, that's usually concerning to me. So that's the other harm reduction approach, is say, okay, make a rule for yourself. Do not drink alone. Just say it. I'm not allowed to. I have to drink with someone or somewhere. I have to go to a bar to drink. I cannot just sit in my house and drink a whole 24-pack. All right. Lastly, this is especially important for kids and teens, parents demonstrating responsible drinking. If parents can demonstrate, like, well, this is how you're supposed to enjoy alcohol, then that goes a long way to send a message to the teen or the kid that, oh, so this is how alcohol is enjoyed, rather than, and this has happened, I've heard many teens tell me this, that, oh, mom had a bad day at work, and so she drank a whole bottle of wine. Or dad had a bad day at work, so he drank a whole bottle of liquor. So, parents demonstrating responsible drinking is going to do a lot of good for that teen or that kid, because it then sets a positive role model and shows them that this is how you actually are supposed to drink. All right. So the next state of change that we have is called contemplation. This is when people are kind of thinking about a change, but are not sure whether or not they should make a change. This is in contrast to pre-contemplation, when they absolutely have no interest in changing whatsoever. So I'm going to talk about MI when we have contemplation. Some people will say that you can use MI even if someone is pre-contemplative. I personally don't agree with that. I think that you do have to have some doubt there in order to effectively use motivational interviewing, because it will work a lot better typically than if you have absolutely no doubt about your substance use. So the origins of MI, it really evolved out of Miller's work with patients who had alcohol use disorder. I think he was at a veterans hospital somewhere in the Midwest, and he was talking with a lot of these vets who were in their alcohol use disorder program, and he was using his Rogerian therapy skills, and that's kind of where MI kind of originated in a sense. He had been told, the literature, the books had told him that, you have to, alcoholics, this is a term they used back then, they have very strong defensives. You're going to have to be confrontational and, be aggressive with them, and, take a brick to their psychological defenses, because that's how strong they are. And Bill Miller just went in, kind of just wanted to know about them and their life story, really. And it was funny because one of the things he said was that, when I went there and I talked to all these people, I was just wondering, like, well, where are all these people with really strong defenses who are in denial and, are totally unreasonable? Because when he talked to them, he found very reasonable people who just were in a bad way. So he would utilize sympathy, compassion, positive regard, and belief that honestly the patient kind of knows what they need to address. They may not know how to address it, but they do have a pretty good idea of like what it is deep down that they really need to work on. So key tenets of MI include partnership. Adopting an opposing approach to the patient will often result in a double downing effect on their initial position. So you tell someone, hey, you have a drinking problem. They're going to say, no, I don't. So rather eliciting a partnership and eliciting common goals helps create a strong alliance and increases the likelihood that the patient will actually accept to whatever plan you come up with them. Acceptance. Patients typically dislike rejection, and when faced with the rejection, a lot of times they will disown that part of themselves. So for example, if you say, well, you have a drinking problem and you need to stop or I'm going to kick you out. Well, I don't have a drinking problem and I don't want to live here anyway, so I'm going to leave. So no progress really made. They haven't stopped their drinking, and that threat that you use to get them to stop is now pushing them out the door. So rather than rejecting, accepting the individual and believing that that person can actually solve their own problems is an alternative way to approaching the issue. Compassion, having the patient's best interests at heart, doing your best to selflessly prioritize their welfare. People, unless they really have a strong personality disorder, they tend to value compassionate providers and are more likely to follow through on our recommendations when we are compassionate. And empowerment. So one of the main points of MI is to help the patient elicit their own intrinsic motivation for change rather than relying on external factors. And so that's one of the core tenets of MI is, to help empower the patient to make the change that they deep down feel like that they need to make or want to make. All right. Skills. Open-ended question. So one of the founders of MI said, if I ever had to name it anything other than motivational interviewing, it would have been motivational conversation. So open-ended questions are naturally going to lead to a more conversational style than closed-ended questions where there's an answer, a yes or no answer, or a one-word answer. Affirmations. Affirmations serve to validate the patient and is one of the core skills in Rogerian therapy. It helps convey unconditional positive regard for a person and help them feel valued. Reflections. So reflections is a core principle of Rogerian counseling and psychodynamic therapy. And basically, a core principle of Rogerian counseling and psychodynamic therapy is that the therapist themselves does not have the answer. It's our job to help the person find the answer. And so reflections are a great way to kind of do that. It's a great way to kind of reflect back to the patient and prompt them to sort of maybe look inside themselves and reflect and think about, well, what do I really want from this? What do I think I need? The other thing about MI is when you reflect, you can help drive the patient more towards this in a more specific direction, as opposed to psychodynamic therapy or traditional Rogerian counseling, which is kind of very non-directive. In MI, you are trying to actually kind of direct them more towards I'm going to make a change and I want to stop doing this behavior that's bad for me. All right, and summarizing. So summarizing is very important because you can use summaries as checks. So this serves to make sure that you actually understand what the patient is saying and that the patient feels heard, and is also a great opportunity to point out discrepancies between the way someone's engaging in a certain behavior and what their goal actually is. Lastly, so there is a lot more to MI than just this slide. There are whole workshops, multi-day workshops on MI. My goal here is just to kind of provide a brief overview and a brief introduction to MI. I realize that out of the 275 people here, there's probably someone here who's an expert in MI. So yeah, if I did say anything wrong, please forgive me. All right, craft. So craft is a novel intervention, and one of the things that makes it so great is that it's really directed at the CSO or concerned significant other, not at the person using the substances themselves. So this is nice because it gives the family member something to do other than just not enabling the person, or scolding or pleading or threatening. So the requirements for the concerned significant other or CSO is that that person is not using substance or alcohol, because that would be very counterproductive. The CSO must learn necessary skills to enhance their own lives. So part of craft is teaching the CSO that, okay, right, but there is going to be more to your life than just this one person who's using substances. What else have you wanted to do with your life outside of this? Are you honestly going to tell me that if this person just stopped using whatever, your life is perfect? All of your problems are gone. Most of the time, the answer is no. The CSO is also expected to do exercises, homework, and role plays that will kind of help them engage with the person who is using substances. There are some precautions to consider when you are going to be using craft. One of the critiques of this is that this intervention is basically utilizing significant others to reward someone for something they should have already been doing. Meaning, so you're telling me I should reward my partner for not drinking like a fish and being hungover the next day. I mean, shouldn't they be doing that anyway? Right. But again, the point of craft is really targeted towards people who have decided that they're just not able to or not going to just walk away from someone who is in the throes of an addiction. Therefore, part of the intervention and part of the program is to discuss potential problems that often co-occur with addiction, such as domestic violence, financial issues, and when someone is escalating. Because most likely when you challenge the behavior or you're doing things that are going to push them towards changing a behavior, they're going to escalate in some way, and what to do in those cases. So, and other core components of craft include functional analysis, meaning really analyzing someone's behaviors, as well as behavioral skills. And effective communication skills, as well as positive reinforcement. So, as well as allowing natural consequences. So if someone, for example, is hungover and later going to be late to work, the tendency for the significant other is to wake them up and let them know that, hey, you're running late for work. So to allow the natural consequences is let them be late for work. Now, a lot of people say, well, won't they get fired? Like, yes, that is a very real possibility. But how are you going to drive home the message that drinking or using substances is not in their best interest when there are no negative consequences, or when you're mitigating the negative consequences? All right, so before I go into preparation, I'm going to just pause and see if there's any questions.
There certainly are. The first one is, what interactions are there for NDRI like I'm going to say it wrong, bupropion. I can never say it.
Mm-hmm. What interactions with what?
Are there for NDRI? They didn't specify. See if you can specify on that one. I'll move on to the next question. If you can add a little more on that one. Do addiction psychiatrists only treat adults, or do they also treat teens?
Well, I treat actually pretty much only teens. Most addiction psychiatrists treat adults. A lot of them will treat teens as well.
Okay, what about the use of tobacco, nicotine on psychotropics?
So yeah, that's actually a really good question. Tobacco, especially, it has a whole lot of chemicals in it, especially the cigarettes, that can affect drug levels, medication levels. So there's a whole list of interactions between tobacco and certain psychiatric medications. Yeah, I probably should have included that actually. So that's a good point. Nicotine can also interact with certain medications, although I will say that the vapes, they have less of a tendency to interact than the cigarettes do.
Okay. Do you ask about cultural attitude regarding the use of alcohol or other substances that you have mentioned?
Um, yes and no. So like usually I can kind of glean from on the inpatient side, no, because I'm usually just treating the patient themselves and talking on the phone with the parent. On the outpatient side, yes, usually I get a very good sense because I will talk to the teen and the parent, and I get a very good sense from the parent what is the cultural value towards substance use. Usually, I would say by and large, it's interesting because I feel like that a lot of the teen values do reflect parental values by and large. Like if parents are not big fans of cannabis or alcohol, the teens know that, and the teens usually, know that this is not such a good thing. Whereas if parents are drinkers themselves, the teens have a more kind of like, whatever, I'm just not, 21 yet.
Okay. What aspects of cultural heritage, beliefs, and practices can be incorporated into treatment and recovery efforts?
Hmm. That's a good question. I would say, I don't know. I would have to, yeah, I don't know. I would have to say, it depends on the specific culture, the specific, spirituality you're talking about. Like, for example, I know in Islam, just alcohol in general is just prohibited, which makes it very easy to address, drinking behaviors. Um, but again, that is under the assumption that the teen is going to adhere to that culture. Sometimes what I get is that there's, a push against the culture. Like, for example, if parents are coming from a culture where alcohol and marijuana are just like, no, you don't do it, the teen, will say, yeah, but that's my parents. That's not me. I'm an American. So it varies from case to case. Um, but that's a great question. I wish I had more experience in that.
What cultural barriers exist for individuals seeking substance use treatment, such as language differences, mistrust of authority, or differing beliefs about the future of addiction or I'm sorry, about the nature of addiction and recovery?
That's, I think that one of the biggest things I've come across is stigma. A lot of people feel like that when they present, people are just going to be very critical of them and tell them, you shouldn't do this. Which I kind of, when I catch people, like my students or anyone really adopting that kind of approach, I remind them, like, they know that they're not supposed to do this. Like, this is not a secret. They know that they're not supposed to be drinking or using marijuana or doing these things. They know that. We have to go deeper than that. Like, it's not enough to just say that. So I think that's a big thing I come across. Um, what were so the question was, what are some cultural barriers to addiction treatment?
Yep, individuals seeking substance treatment, such as language differences, mistrust of authority, or differing beliefs about the nature of addiction and recovery.
The differing beliefs, I would say the biggest difference I see are people who are actively addicted. They have a very, I feel like if they're in that pre-contemplative state, they have a very different belief set than people who are contemplative or just like ready for change. That I would say is probably I would think that's far more impacts their mentality than from what I've seen of like culture or like, other aspects. It's just, do they feel like that this is a problem or not?
This is a little clarification on the previous one. You mentioned interactions for SSRIs and antipsychotics. So what are the negative interactions for the NDRIs?
Hmm. Um, so with bupropion in particular, because it increases dopamine and norepinephrine, I would say that if this is a challenge though, that if someone's using stimulants, I could imagine that bupropion wouldn't be a very good medicine for them to take. At the same time, bupropion has been shown to decrease, I think, cocaine use when combined with naltrexone. So that's kind of why I'm struggling to answer that one, because typically I would say that, yeah, bupropion, I probably wouldn't use it with marijuana because it has a tendency, marijuana withdrawal can cause irritability, anxiety, both of which are problems with Wellbutrin or bupropion. Marijuana withdrawal can also decrease appetite, which is also a problem with bupropion. The other thing I would be worried about with that one is if there's any sort of, I wouldn't use actually Wellbutrin or bupropion with alcohol use because it lowers the seizure threshold, and if you just stop drinking all of a sudden, it could increase the likelihood of a seizure. So yeah, so that would be one thing I would not use Wellbutrin with is alcohol use.
Okay. And then I'm sure this is in regards to natural consequences. It says, what about when they're married and as a spouse, if you let them use their job, lose their jobs, then it affects the whole house, kids, income-wise, etc.
Agreed. That was my question when I was reading about craft. I was like, wait, so you're telling me that this spouse is just supposed to let the other spouse lose their job totally and like, just deal with it? I guess if I were, I don't know, see, that's a great question for Bob Myers, who kind of did the whole craft thing and then, was one of the founders of it. I think he might say something like, that, so are you assuming that they're just going to keep the job anyway? Like they're just, they're going to perpetually keep drinking and they're just going to keep being employed? Or are they already in danger of losing that job? And, you're just kind of like maybe making it happen a bit sooner than it would have otherwise. But yeah, that's a great question. I think they address it in their book. I just don't remember the answer off the top of my head. Again, same thing for MI. I know there's probably someone out there who's an expert in craft. If there is, feel free to chime in. But yeah, they do trainings on craft. There's a whole book on craft and how to do it. I know about it. I've read about it, but I'm not an expert in it by any means.
Okay, excellent. That was all the questions overall. Still getting a couple questions on the CEU certificate. So just another reminder, they will come out next week with the presentation via email to the email you used to register for today. All right, that's it.
Cool. All right. Preparation. So this is a phase where people will consider different approaches to try to figure out what method will be best for them and optimize their chances of success. A lot of times people will bypass this step and go right towards action, which can increase his chances of failure and relapse. So the interventions that can be used are basically craft, harm reduction, 12-step facilitation, medication-assisted treatment, and contingency management. for this section, we'll be focusing on 12-step facilitation and MAT. So in 12-step facilitation, you have 12 individual sessions. There are 10 one-on-one sessions as well as 2 couple sessions. There's max of 2 emergency classes. Emergency sessions, I meant. And, you know, the session outlines is as follows. The first session is more like an introduction, going over previous treatment, negative consequences of use, the program overview, what a possible diagnosis might be, recovery tasks, and then sessions 2 through 11 all have a very similar structure in that, you know, they review the previous session, they go over new material, they go over the recovery tasks, and then there's a summary at the end. And then, so here are 10 topics that are outlined, you know, and typically they will spend either one session or a certain number of sessions going over each of these. So there's a program intro, there's step 1, which is acceptance, and then there's steps 2 and 3. So step 2 is the acceptance that a person is ill and that only the higher power can restore them to sanity or normalcy. Step 3 is turning over your will to that higher power. Then there's getting active, reviewing each day of sobriety, reviewing urges, reviewing your slips, reviewing your journal. Then there's like a genogram where you go over your family history, people, places, things, and routines. You know, you really kind of go over what were the people that you used with, the places you used, the things you used, the routines that were that incorporated use, and how are you going to now live your life without those. HALT, which is hungry, angry, lonely, and tired. All these things can precipitate a relapse. Steps 4 and 5 are your moral inventories, which is like a history of all the things that you kind of have done in the past where, you know, it's important to be balanced and honest about some of the negative things that you might have done or your use might have precipitated or caused you to do. And then, let's see, the next one would be sober living, how to live a sober lifestyle, and then the final session is sort of termination. Lastly, the couple sessions will often go over enabling and detaching. All right, MAT. So medication-assisted treatment. I'm going to just kind of go through a bunch of the different medication options for different substances here, and just highlight what each of them kind of does. So for alcohol, we have acamprosate or Camprol that decreases cravings. You do have to take it like 3 times a day. I would say it has minimal adverse effects and it's pretty well tolerated. The biggest critique of Camprol or acamprosate is that it doesn't do much. But the studies have shown that it actually does help reduce drinking and does help maintain sobriety. So disulfiram, this is the antabuse, the one that makes people sick if they drink. People have had really sensitive reactions to it, including like some healthcare people using hand sanitizer and getting the disulfiram reaction. One person I remember went to like an Italian restaurant and there was some white wine sauce or something on the pasta and he developed this disulfiram reaction to just that. So that can be that can limit its use. And when I say the disulfiram reaction, what I mean is you get a very fast heartbeat, you start flushing, you get very thirsty, nauseated, dizzy. It can also interact with certain medications as well. Naltrexone is an opioid antagonist. You cannot use it if someone is on buprenorphine or opioid pain medications. You want to be cautious if they have any sort of liver disease, and then it can worsen depression because sometimes it basically blocks your pleasure receptors in a way, and it can like precipitate anhedonia. So someone can actually get a little bit more depressed when taking this medicine in particular. Side effects include nausea, vomiting, and decreased appetite. Opioids. So again, naltrexone often can be used for opioids, including its long-acting form, which is Vivitrol. Buprenorphine is a partial agonist. it has what we call a high binding affinity, meaning when you have the opioid receptor and you have the buprenorphine, it binds very tightly. If you have an opioid receptor and an opioid like fentanyl or heroin, it binds. And then if you use buprenorphine on top of that, the buprenorphine will come in, replace the fentanyl or heroin, and then precipitate a withdrawal. So that's one of the cautionary things about buprenorphine is you actually have to be in a mild withdrawal before you can start taking it. Some of the side effects include sedation, nausea, constipation, as well as dizziness. There are protocols out there where you can get someone started on buprenorphine in as little as 2 days. So on day 1, they take up to 8 milligrams, and on day 2, they take up to 16. You might want to avoid other sedating medications such as benzodiazepines or maybe even gabapentin. Methadone. So quite restrictive. You have to enroll in the methadone program. There are some interactions with methadone and other medications, particularly QT prolongation, which we spoke about earlier, can be an issue where that heartbeat gets spaced too far apart and can cause an arrhythmia. The nice thing about methadone is you can earn take-home doses, and it is a full opioid agonist. A lot of people also feel like that going to an opioid program every day keeps them on the straight and narrow. They feel like they need that in order to maintain their sobriety. Cocaine, topiramate, has been found to be helpful. Unclear why. The mechanism's not really fully understood. It's thought to help by enhancing GABA and decreasing glutamate in the brain. GABA is an inhibitory. It sort of, brings everything down on the brain. Glutamate is more excitatory. It brings everything up. Side effects include decreased appetite, cognitive slowing, sedation. It is also used to help with migraines. Long-acting amphetamines this is more like kind of a cutting edge, sort of, I don't want to say controversial, but I will say a lot of people have strong opinions about it, that long-acting amphetamines like Vyvanse, some of them have been shown to decrease morbidity and mortality with stimulant use, including cocaine and meth. I don't know off the top of my head of any study that's shown that they help maintain sobriety itself. But there was a study out of Europe that showed that it actually, Vyvanse, and which is lisdexamfetamine, and modafinil, decreased overall mortality in people who are using stimulants. So Wellbutrin, naltrexone, they also, that combination has been shown to be effective for stimulants as well. Which I think we talked about that in a bit because someone asked a question about it. Now with cannabis, mirtazapine is an atypical antidepressant. Oh, wait. Sorry, I'm jumping ahead of myself. Mirtazapine also has been shown to help with methamphetamine. It's an atypical antidepressant. It can help with sleep appetite at low doses. It may act as a stimulant at higher doses. There is very limited evidence for this intervention. Cannabis, N-acetylcysteine, or NAC, one trial found it helpful in adolescents and young adults. However, another study found that it had no difference. Gabapentin has also been found in at least one study to show a decrease in cannabis use and help promoting cessation of use. Topiramate has also shown in one study to be helpful in stopping cannabis use. Again, the evidence for all of these in the cannabis section is not that great. So, and it's pretty quickly evolving. Just a year and a half ago, topiramate was not in there, for example. And the other study for N-acetylcysteine, the one that found it was not as effective, that found no difference between the two groups, that was not there either. So that's more rapidly evolving. It changes like every year. Lastly, Seroquel. There was one study that found that people on 300 milligrams of Seroquel nightly, a lot of them went from heavy cannabis use, meaning multiple times a day or daily use, to moderate, meaning only like maybe several times a week. So obviously, doesn't mean it stopped completely, but it did help cut down significantly. All right, now the action phase. So this is when people are ready to make a change and take the next step. It requires commitment, time, and energy. So in this phase, we'll be reviewing CBT and CM, which is cognitive behavioral therapy and contingency management. All right, so CBT, I'm not going to go into too much detail on CBT related to addictive disorders because Bruce Lees does a really good job of going through it, and on CBT for addictive disorders. So he has done a fair number of workshops on the topic too, but I will be covering it briefly. So there are, as many of you know, there's a lot of different therapies that are under the umbrella of CBT, including the acceptance and commitment therapy, rational emotive behavioral therapy, I believe, behavioral analysis, craft, dialectic behavioral therapy, contingency management, mindfulness-based cognitive therapy, exposure and response prevention. So there are 5 essential components to CBT: structure, collaboration and alliance, case conceptualization, psychoeducation, and standardized techniques. One of the things that I find very useful about the CBT model is how they conceptualize cases. And so this is sort of an example of one. This is sort of like, the overview that in addiction, you have childhood developmental experiences, genetics, and exposure that leads to the development of vulnerability through cognitions, behaviors, and illness, and then leads to experimentation and engagement in a problem behavior. As an example, so we have this child who was exposed to cannabis in utero for the first trimester because, let's say, mom did not know she was pregnant until about 3-4 months into the pregnancy, and she was using cannabis, as was dad. In pregnancy, mom stopped using cannabis and the second trimester, but dad continued to use throughout the pregnancy. Around age 5, mom and dad separated. Dad became distant and not so involved. Around this time, he started going to school. It was noted he was very hyperactive and attentive. It was very difficult for him to make friends. And then later on in life, he was getting bullied in middle school, became very anxious, avoidant of school. But when he tried to avoid school, he would get in trouble. So he tries cannabis and finds himself to get much calmer, and his anxiety gets better with the cannabis. So just with this case example, you can see how these factors are coming through. He was exposed in utero. Both parents have an addiction history. There goes genetics and exposures. In terms of cognition, father left at a young age. You have issues with abandonment, possibly attachment. Behavior, hyperactivity, inattention, difficulty making friendships, illness, issues at school leading to anxiety, feelings of depression from being a failure or being a burden on other people or not being as good as others. And then he's by the age of middle school, high school, child is desperate for relief of symptoms, and any efforts to avoid the trigger, peers or school, is met with a resistance from parents. You have to go to school, you have to interact with other people. So what happens is he turns to substances to tolerate the distress. And that's with CBT for addiction. I find that very helpful with the case conceptualization because I feel like it does a really good job of going into the different categories. All right, contingency management. So the underlying principle is that people are given positive reinforcement for not using, if people are given positive reinforcement for not using, they're less likely to use. The 7 core principles for contingency management are the target behavior, the target population, type of reinforcer, the magnitude of the reinforcer, the frequency of the reinforcer, the timing of the reinforcer, and the duration of the reinforcer. So one meta-analysis from 2008 found that it was actually twice as effective than CBT for help with substance use disorders. So that begs the question: if contingency management is so effective, why isn't it used more? Well, awareness is lacking. The frequency of visits can be an issue, that people have to come once or twice a week. Immediate reinforcement is needed, which can sometimes be difficult to do. Lack of funding at the federal and state level, as well as at the community level. There is that mentality of, well, why should we pay people to not use substances? They shouldn't be using substances anyway. Training, I feel like, is also an issue. I was actually at an institution that used contingency management, but I had asked actually a couple of different people, like, hey, do you know someone who knows how to train people in contingency management? Because I'd like to talk to them. I never really found anyone. So it's hard to find good trainers for CMS from what I could gather. Two commonly used forms of contingency management include vouchers as well as entrance into prize draw, so like raffles. All right, maintenance. So this is the phase when people maintain the change they have decided to make in their life. In some ways, I would say this is one of the hardest phases because of how long it is, the lack of positive feedback over time, and it's in this phase that people start thinking, everyone said that once I get sober, my life is going to be much better and everything is going to be awesome. When's that going to happen again? So I'm going to be reviewing therapeutic community and relapse prevention. So in terms of therapeutic community, the National Association of Recovery Residences have 3 levels for places where people will go to be in a kind of like a sober environment. Level 1 is a peer run. Level 2 is a monitored, and level 3 is more like a professional supervised type of environment. So level 1, these are democratically run with a senior resident, less formal rules, and it's not as supervised. Emphasis is on peer support. Oxford homes are a good example of this. Level 2 are peer-run facilities that are often like in a single-family home. They usually have a senior resident and a house manager. There are usually peer-run groups, certain house rules. These are your typical SLEs, sober living environments. And level 3 is supervised. So these are licensed facilities. There's an organizational hierarchy. There's policy and procedures that are strictly adhered to. Staff are usually certified. Urine drug screens are often done, and you're expected to do them. These are usually costly and expensive. All right, lastly, relapse prevention. As the name implies, the goal of relapse prevention is to minimize chances of relapse. So some of the topics that are covered in relapse prevention include defining the problem, which include pros and cons of using, how others see substance use, education, which is learning about different substances, as well as some of the dangers of using substances. What are the patterns of use, like the cycle of addiction, triggers and coping, 12-step work, goals of recovery. Then there's preventing relapse, which what are your warning signs? What is peer pressure and how to deal with it? How do you enable positive influences? What are positive influences? What are negative influences? What is enabling? Relationships and substance use. You might do a genogram. There's peer, how to handle peer pressure. Communication skills, honesty, self-talk, I statements, active listening, managing emotions, specifically shame, guilt, fear, and depression. All right. Sorry, I'm kind of rushing through it because I noticed we're short on time. So these are the states of change, all the different interventions in one nice slide so that, for your reference. And lastly, questions.
There are some, yes. To start, let's see. Given that there are precautions regarding using the don't drive, don't work, don't go to school, how does safe site approach work in a city like Phoenix? If folks come to use in a safe site, how can we let them get behind the wheel when they leave the site? In a small city with viable public transportation, I can see that working, but in a city like Phoenix, which does not have a robust public transportation system, I wonder how that could work in a responsible and safe way, just thinking about it from a logistics perspective.
Yeah, agreed. Like in a city like Phoenix or even like Los Angeles, where there isn't a good public transportation infrastructure, um, I think it can be very challenging. I That's actually one of the things which I really kind of like about I know probably people have a lot of different opinions on it, but like Waymo and these autonomous vehicles, like it's kind of more private. Hopefully, it'll be more cost effective than Uber or Lyft, and people will be able to, hail them and get to them. I, on the other hand, I think it can be also a little bit more dangerous because there's no person there. At least when you're intoxicated in an Uber, if you're in real trouble, the Uber driver will take you to the hospital. At least, if they're a good person. So yeah, it's a challenge. I think the other thing I was kind of trying to hint at with that or try to drive home with that was, especially for teens, they will be at a friend's house and like use something and then say, hey, let's go to Wendy's or let's go to In-N-Out. It's like, no, you're not supposed to do that. If you're using, then you just stay there. Don't go to Taco Bell.
Okay. And this one says, thank you for responding to my questions. Final question. How does historical trauma, such as the experience of Native American or indigenous populations, contribute to substance use patterns within those communities?
Well, that's a good question. And I feel like it's one of the issues I see in Native American communities and in just a lot of communities because there's sometimes stigma around getting, mental therapy or, psychiatric medication. Whereas it's almost like there's less stigma to drinking a beer or throwing back shots, than taking a pill. So I feel like that a lot of it might be self-medication. There is a significant trauma history, especially in the Native American community. And it's like there's so many complex issues, especially with the Native American community, that I don't have a good way of even encapsulating it because it's like, a lot of, in my conversations with some Native people, it's like you've been stripped of like, your history or culture in a way. And, you have almost no access to medical help, mental health, and you're just supposed to like live. Like, and there's the teens that I talk to say like, there's literally nothing to do. So, I mean, that's what I mean. There's just like so many issues, especially with the Native American community, that it's just like, I don't know, I don't even know how to start to talk about it.
Do you know anything about the research regarding GLP-1s and alcohol?
Yeah, that's a new thing that's coming out. It's funny because someone just mentioned that the other day, and we jokingly said like, "Wow, what can't they do?" The GLP-1s. Um, it is emerging. I would actually say that it looks promising. I just don't know if it's going to pan out. And the reason why I'm skeptical about it is because with N-acetylcysteine and adolescents, people were swearing up and down by it. Like 2 years ago, 3 years ago, they were like, "Oh yeah, this is great. It's gonna, this is gonna work flawlessly." And then another study came out showing no difference. And now everyone's like scratching their head, like, "Wait, what?" So that's one of the problems I feel like, especially in medicine nowadays, is that when there's a study that gets like kind of a newsworthy result, that gets publicized very quickly. But then when the other study comes out that contradicts it, no one hears about it. And so it's like one of those issues where, because I didn't hear about the N-acetylcysteine study that contradicted the previous study, I had to go and look for it, then I found it. So that's my worry with the GLIP thing is that, what happens if it's 6 months or a year, we get another study that contradicts this one, and then no one says anything, and there's no published article about it because no one wants to hear that, oh yeah, we found another study that contradicted a previous study, and, you know, surprise, it's actually not very helpful.
Thank you. Is there a set span of time that a person should be on methadone for? Are there any long-lasting negative effects when people on methadone for 10 plus years?
Um, that's a great question. I mean, it's really, I've remember having multiple conversations with people about both methadone and Suboxone. And the best person to answer that is the patient themselves, because I would ask them, so how long do you plan on being on this for? And a lot of times, especially if they're younger adults, they will tell me like, oh, just probably next 2 or 3 years. I'm like, okay, well, you've already been on it for 5 years. So another 2 years will make it 7, which is the better part of a decade. Do you see yourself being on this for 10 years? And when you put it to them that way, then they really start to think like, oh, has it really been that long? So I think that methadone, I'm not a fan of anyone being on any medication perpetually forever unless they really, really need it. If I have someone who I've tapered off of methadone 3 times, and all 3 times I've tapered them off of methadone, they've relapsed on opioids or fentanyl, I'm probably not going to want to taper them off again. If I have someone who I've never tried to taper off completely off of a methadone or a Suboxone, and they're resisting it, I mean, my opinion is it's my job to kind of talk to them, explain to them that, hey, if this is what your life would look like if you're going to be on this for the rest of your life, is that really what you want? You know, a lot of people, I'll say, well, what are you going to do when, because right now you have like one person I'm thinking of, I remember to asking him, like, right now you have a 3-year-old, what are you going to do when he's 13 and ask you, hey, Dad, why do you take that thing every day? How are you going to explain that? So, and that really resonated with this guy. He was like, that's a good point. Like, what do I do? So, yeah, so short answer, engage the patient in a conversation and see when are they ready.
Okay, thank you. Do you have any medication recommendations for a client who is diagnosed with ADHD and has taken every non-stimulant ADHD medication as well as long history of methamphetamine use but currently sober?
Oh, so he's taken every non-stimulant?
Correct.
Yeah, he should be on a stimulant. I would say Vyvanse. Like, this is one of those things where, yes, someone has a history of methamphetamine use, but if they've been sober for a long period of time, I would probably not hesitate too much in putting them on Vyvanse, because Vyvanse is an amphetamine, and as long as they're willing to do the urine drug screens necessary, if they ever do, let's say, relapse on methamphetamine, that's a different metabolite. So if they relapse on meth, the urine drug screen will pop up positive for methamphetamine, in addition to amphetamine. So, yeah, and the other thing is that, like, I've worked with a lot of patients like that in New Mexico who were using methamphetamine, but a lot of times they were actually self-medicating their ADHD with the meth. So yes, historically they would snort it or smoke it, but one gentleman actually who was like 70 or something was actually mixing it in with his coffee because And I asked him, like, well, why are you doing that? Why are you taking it that way? Because most people who use meth will like snort it or smoke it. Why are you mixing it in with your coffee? And he said it lasts longer. And yeah, basically, I asked him about his childhood, and his childhood was very consistent with ADHD. Never did well at school, was always getting in trouble. He was obviously, he was raised in a different era, so the response, the discipline of choice was physical punishment. So he would always get beaten up, either by the teacher or his parents. And he eventually dropped out of school, joined a biker gang, started selling that, methamphetamine crank. Um, and that's how he got into it. But yeah, I mean, he always had ADHD. That never went away.
Thank you. Is it required for a patient to be in counseling of some sort while being prescribed addiction medications to help increase refusal skills, increase emotional tolerance, and deal with any trauma or other issues?
I think that any person who's suffering from a mental health issue or an addiction issue should be engaged in therapy. Um, but I am also a fan of like having a goal to the therapy. Like both medication and therapy, we should know when they're over, right? Like I don't like medications being prescribed, decade after decade. Similarly, therapy also should have a set, number of goals, and we should have you know, we should know that like, okay, so this is when the therapy will end. I mean, it could be 5 years or 10 years, but we know that this is our ultimate goal, what we want to accomplish and get out of this, and that we should end. Um, if someone has already done, like, let's say someone was in intensive therapy for 10 years and, they tried tapering off of Suboxone 2 or 3 times and wound up relapsing each time, but they have gone through intensive therapy for like their trauma and their other mental health issues and their addiction. It's just that for some whatever reason they cannot taper off. Then sorry about that. Then I would say that yeah, then they might not need it.
Okay. If you have to jump off, we're coming up on 1:30. Reminder, CEUs and the presentation will be sent to your emails next week. Dr. Ghafoor, do you have a couple minutes for a couple more questions here?
Sure.
Okay, excellent. Thank you. You're getting a lot of thank yous, excellent presentations, very informative in the chat. So it's going crazy with lots of thank yous to you. What are some alternative medications for clients who cannot use a benzodiazepine for anxiety because they're on methadone?
So if you're on methadone and you have anxiety and you cannot, yeah, if you can't. So honestly, in terms of benzodiazepines, I really don't like using them long term. If you're talking, my opinion on benzos is that like you really shouldn't use them for more than 6 months, maybe a year. Like they're really an acute intervention for a specific period of time. And you shouldn't be on them for just years and years and years and years. So if it's anxiety, that's a disabling thing, day-to-day stuff, ideally a combination of therapy plus SSRI, SNRI. I'm actually, even sometimes I've found that like guanfacine, which is an ADHD medication, can help with that. So addressing the underlying reason for the anxiety would be helpful in addition to being on one of those. But if it's genuinely like I have a panic disorder and I use my benzodiazepine once a month because I don't know when it's going to happen. I just have a panic attack and I just use one benzo once a month. That's like a low dose. Probably that'll be okay even with methadone. The times we get into trouble is when we have regular daily benzodiazepine users who are also on methadone, then that makes me nervous.
Okay. Does staff at Aurora have specialized training for patients with chronic illness and addiction for patients under 25 years old?
Katie, that's a you question.
Well, I would say you do have that specialty.
Me, I do.
So yes, we do. Absolutely. Um, for clients who are self-medicating for ADHD, for example, what are your thoughts on total abstinence and not taking any psychiatric medications? I work in criminal justice setting, and many of the professionals I work with believe that ADHD medication treatment only reinforces their addiction or need for the stimulant.
I mean, if you have someone who has ADHD, and it's sort of like forcing someone to live their life with, one arm. It's like, yeah, you can do it. It's just that it's limiting. Um, so especially when all of these expectations are on you that are on the same, the expectations placed on you are no different than the people who have both arms. So I would say that if there are people who feel like that, in the criminal justice system that, oh, these guys shouldn't be on stimulants because it will further their addiction or something like that, have them talk to a physician or someone who's actually an expert in the area. Like I'm happy to talk to them at transition if they want, because that's not my opinion. My opinion is if treating their ADHD makes them less impulsive and is going to make them less likely to use marijuana, fentanyl, alcohol, then to me that's a win. And I have and there are non-stimulant options for ADHD. So number one. Number two, even if they do need a stimulant, that's okay. I have Vyvanse. Part of the impetus behind Vyvanse was that we needed a stimulant for people who have substance use disorders that you really can't just snort. That's part of the reason why Vyvanse came into being, and that's kind of like it. I'm not going to say it's impossible to get high off of Vyvanse, but if you take a lot of Vyvanse, you're going to be up all night, and it's just going to be very boring. It's not like Adderall tablets where you crush them and you snort them and you're like, ooh, this feels good. No, it's very, very, it's really different. And again, in the criminal justice setting, sure. I mean, you got people in jails who are snorting Wellbutrin and Seroquel. So yeah, I mean, people can get high off of Benadryl if they want. Doesn't, I don't know.
All right, and the last one in the Q&A is not a question, but she said, I hear this too, especially Vyvanse and places like Mind 24/7 and many clinics won't medicate it. So good answer on that one. And just a reminder to everybody on, Dr. Ghafoor is a psychiatrist with Aurora Behavioral Health, but they also have Transition Center down the road. And we will share some of their materials when we send out the presentation week as well.
Katie, one thing about Mind 24/7, they don't prescribe any controlled substances. Any.
Okay.
Zero. So, because I know that because I know providers from there, and they don't.
None.
Zero. So, it's not a Vyvanse thing. It's a controlled substance thing. They don't do that.
I love some of the chat. Thanks, Doc. Very informative and down to earth, knowledgeable, realistic views. Kind of doc I would enjoy picking your brain. Thanks. Appreciate you. So on that note, we will say goodbye. Thank you, everybody, for joining us. If you're not signed up for our webinars, reach out to me and I'll get you on for the future ones. Thanks, Dr. Ghafoor. You were awesome.
No worries. Thanks, guys. Bye.
Thank you.